Oh, Welcome, Abraham.
John,
Thank you so much. How are you?
This is the right Abraham.
That's
Well,
true.
we had a Jordan neurosurgery grand rounds on Wednesdays with Ibrahim Sabaya. I don't know if you've heard of him.
Yeah, I have heard.
Yeah, he's a Jordanian neurosurgery educator. And,
How are you been?
good, good.
How's, how's your family? Everyone is good?
Yeah, everything's fine. Fine.
Okay.
Everyone's recovered from the COVID's a memory, a bad memory.
Yeah, really bad memory.
It's certainly something that no one expected.
That's true.
It came out of nowhere.
Is it?
Out of nowhere and all of a sudden changed the world.
Yes, it's really an experience for life because people have been stuck for a long time.
Yeah. How was it where you at? Pretty good?
Yeah, I'm doing great. I'm still in Ashan. I still have like 1 year left.
Okay, you're in Shanghai now, right?
I'm in Shanghai.
Are you working with Dr. Ben?
Yes.
Oh, cool.
Mm.
Oh, good.
Yes.
Man, that guy does a lot of work.
He have a lot. He's an excellent surgeon. So positive.
Yeah, he must be. But he's very active. Hey, let me put my camera up there on social media.
That exactly. So
he really shows how to budget his time. Obviously he knows how to budget his time, like every neurosurgeon.
Right.
You guys all have to learn, how to
He's so patient.
allocate your time.
Always calm. Try to show up every detail you need. Like you can always be with him.
Yeah.
He's an excellent.
I'm very he got me on WeChat. That took a while, but I'm on there because a lot of Westerners don't even use WeChat.
Yes.
And it's obviously the best tool in China, obviously.
Yes.
I'm sure you were impressed by it when you got there, how they use it for everything.
Yes. It's stay in my mind, and like I have seen many neurosurgery department before, but this is the most huge department I never been before.
It's the biggest, obviously.
Biggest. We almost have like 800 beds and 50 operation room.
Wow.
For some days, we have almost like 200 operation per day.
Wow.
It's so massive.
Wow. The numbers. I mean, now do the neurosurgeons get to touch the knife, the residents? Because some places you get the knife really quick. You know what I mean?
Yeah, I know.
Some places you have to wait and a long time.
That's true.
Is it true there the residents like it because they get a lot of hands-on experience?
But it depends. I think it's much better for somebody who have started before somewhere, who is have at least the good skills.
Okay.
That is the most important. But for somebody who's just coming for begin and you are not good on the language, it's gonna be very difficult.
Yeah.
Yeah. So
it was challenging for you.
Yes.
And how many years have you been studying Chinese?
I have been studying Chinese maybe almost 4 years because recently I didn't have like a lot of course, but I just try to improve my skills by listening people, try to ask what is this, and that's why my skills get better. My first year was a little bit challenging, but finally now I can work peacefully without any translation. I don't need anyone can help me to ask any tool.
Well, I'm older, so I got to tell you a story. That's what old people do. But I was in Mexico, the same thing as you, learning Spanish to go to medical school because I couldn't get into a U.S. school, and I had to learn Spanish. So I went to Mexico. They had a 5-year intensive Spanish, 5 hours a day. It was good. It was good to get a basis. And I had a friend at the same time from California. He's now an anesthesiologist. Come
Okay.
down and did what you did. He just talked to the people, learned it on the street, learned it, and he was much more ahead of us. He lived with a family, a Spanish
Yeah.
family. They spoke Spanish, obviously, at the table and everything else, and he surrounded himself with Spanish.
Mm.
So
That-
that kind of told me, he said, wow, it's valuable experience to be with people and
It's
talk.
really a valuable experience. Yeah, it's
Yeah, so that's,
quite
I
interesting.
congratulate you. It's ambitious, but it can be done. It can be
Yes.
done.
Yes.
So, okay, let me do some paperwork here. Okay, I'll be
All
back.
right. I'm gonna be back too soon.
Okay,
Thank you. It
you're
was good
welcome.
seeing you. Mm.
Yeah, you can help me too, Abraham.
Okay, I will keep in here. Mm.
Yeah, you know, Abraham, you can, I mean, in the future, if you
Of
ever
course.
want to give if you ever want to give a broadcast, or
Of
you
course,
want,
I will. I'm expecting that because our country is not that very good on the webinars, but I'm having that plan soon to start even also the international webcast with you.
oh, okay, well, yeah, you're saying you like to broadcast, you know how to use Zoom and everything.
Yes, yes, yes. I really have to because now we are getting a little bit of number on neurosurgeon, so I think it's gonna come slowly. If there are no too much neurosurgeon, it's gonna be difficult because everything have to be done by you. It's a little bit difficult.
Well, you know, what we could do if you want, we could arrange for you to do a webcast and I'll broadcast it on Neurosurgical TV. And it can
Okay.
be in Chinese too.
Okay. All right.
Okay, you can be in Chinese. It doesn't
right.
have to be English. The whole thing can be in Chinese. I'll
Mhm.
basically introduce this as Ibrahim Ibrahim and from Africa. He's in China.
Right.
And from here on, it's going to be all Chinese. And then you
Right.
do the whole thing in Chinese.
Okay. That'd be great.
Just keep in mind, okay?
Okay. All right. Keep in mind and keep in touch too. Thank
Okay.
you, John.
Okay, you're welcome.
Mm.
Good morning, Harshad. And Hello, Warlocks, are you there? Okay, we're starting in about 10 minutes. Check on a few things. Starting in 10 minutes. Hey, Warlocks, are you there? We need to make sure your microphone works. Ben, okay, Ben. Warlocks, are you there? Ben's here. Good
Hello,
morning,
John.
Ben. How are you doing
Hi.
today?
Fine.
That was a very good tribute yesterday that you gave for Yuha.
You see it?
Yeah, it was great, great. Yeah, I'm gonna
Thank you.
start a chat with WhatsApp for people. You know, he met a lot of little people, you know, all over the world.
Yes.
Not just famous people, but
Yes.
I'd like to give them a chance to say, well, you know, where they met him. You know, in
Mhm.
Latin America, because he did a lot of traveling.
Yes. Yes.
Latin America, Mexico, Peru. He's been in many places. So I'm sure a lot of people would like to give their stories about how they interacted with him. Warlocks, Ben is here. Come say hi to him.
Hello.
Unmute, Warlocks.
Hi.
Hi. Hi.
Yeah,
Hi.
hi.
Aurora.
Long time no
Hi.
see. Okay.
Yeah.
Hi. How's everything? Yeah, I did not hear it yesterday. And with the loss of Juha too. That's quite
Yes.
shock.
Yes.
Yes.
This is a sad week for us.
Yeah, it's happened so sudden. Actually, so I just heard firstly from Professor Ive and then just like asked John if it's real, and he just like not believe it too. Yeah, it's just quite
Yes. Actually, he's supposed to stay for longer time in China, but he got some news. Actually, it's I think it's rumors about the bad condition of Chinese pandemic. Actually, we all,
oh okay.
yeah. So he was terrified, and he go back after the Shaolin conference immediately.
Oh, okay. Yeah.
So he lived there by himself alone.
Oh, in Finland?
Yeah.
Okay.
So if he stay longer, I don't think he would this would happen to him.
Didn't he dislocate his shoulder like
Yeah.
a week before or something?
Yeah,
Did you hear that, Ben, that he dislocated his shoulder? I don't know if that happened a week before or a couple of weeks before. So, but that was an excellent tribute yesterday. So, Warlock, man, you've been on the social media.
Oh, I just like
Well, I think
right
it's
now.
great. First of all, I think it's great. You're active
No,
as
no,
heck.
no, no. Actually, last week I came to Bangkok, specific to meet Professor Ive. He come and introduce exoscope in Bangkok, so I fly from my hometown to see him. Yes.
Oh, yeah, I saw that
Yeah,
picture.
yeah,
met-
and see, yeah, I
That's the
met
first-
Professor Ivan. I like, I come there and then all the meeting was like, finished already. So it's so surprised. So he gave me like many like personal private lectures, and he talked about the exoscope, in which was like, it's really amazing how he introduces to me. And just like we have a great talk. Yeah, it's really nice. And he gave me the books. Yeah, and we talk about Juha. Yeah.
Have you had any experience with that, Ben? The exoscope, excuse me. It's a new device that, can you describe it to Dr. Ben, please? Warlick's the robotic
What I'm understanding is kind of like, it's because nowadays what we use is the microscope, in which for me, I kind of like, it's kind of like, huge and big and take a lot of space. So what I'm understanding in my understanding, it's just like something that you just need only the camera, and something that can interpret that maybe maybe on the televisions, or maybe in the future that they have the Visual Pro or something like. So I think it's for me, because I now that I kind of have the VR and AR in my home. For me, it's kind of like, it's amazing. So which means that it's kind of like use the eye tracking. So for me, it's just kind of like, you just play game. But the thing that is used by the hand is just like exactly like the PSP that I playing the VR game right now. So it's kind of, you're holding two things. But the one thing that I think that is for the games itself, it does not have the touching sensation or something. But
you use your feet too, right? Don't you use your feet?
Yeah, but I mean, I use the foot switch for when I do the surgery. So for me, for the foot switch itself is not my problem. But I mean, for me, I just feel like, oh my God, it's kind of like, give me the freedom to move, move as fast as I wish. So that's a benefit, and I'm really exciting. Yeah, about that. Yeah, it's very great. It's funny because I just cancel all the work only that day and just like fly and then join the conference and see Professor Ive and fly back.
Yeah, Ben, you've been traveling a lot, right? You've been doing a lot of conferences. You just got back from Indonesia.
Oh yeah.
No. I'm going to
Where'd you go?
I just come back from Malaysia and
Malaysia. Okay.
Yeah, I'm going to Indonesia, and this September I will go to Harvard.
Oh, okay.
Yeah, for some presentation. And to Istanbul, yeah, a lot of countries to visit.
Yeah, the makeup. I gotta get out too.
So may I share the video for you, huh?
Yeah, sure, that would be great. Okay, okay, we'll introduce you first, Ben, and then you share the video, Yuha, okay?
Yeah, okay.
Okay, Warlicks. So Warlicks, I'll introduce you, and then you introduce Ben, and Ben will do what he wants, okay?
Okay.
We got a few minutes. People come late to this. Even the speaker.
Yeah.
Nice background, Wallace.
Nice
Nice background. That's a nice background. Colorful.
So, yeah. I did not do so
I
much.
tell the guys from India, use your background. You got a chance to, to show your hospital or show something.
Oh, it's still small. It's just like little by little. I just only me like that do everything. I'm not a superwoman that can do everything at the same time. I do not have a big.
You're a neurosurgeon. You got to be a superwoman. Come on.
Oh, I know now. I think I'm superwoman already. I just like do everything, like everything.
Even announcing. Okay, one minute. People will come. Oh, we can't start really. James, where's James? Let me check.
Oh, James. Dr. James just say hi, John. So maybe you should
Oh, there he is. He's here.
push
He's
him.
here.
Yeah, yeah, he's waiting.
Come on, James.
Hey, good morning.
Ben's here.
Yeah. Hello,
Hey, good morning.
hello, James.
Hi, Ben. Good morning. Good to
Hi,
see you.
good morning.
And
So
Wallace is here.
what's the
Go ahead,
time
Ben.
for you for you?
Oh, the time? Yeah, the
Uh,
time about 50 minutes, something like that. Is that what you're asking?
No,
Oh, my
no.
time, it's 8 o'clock,
Yeah.
New Jersey, 8 in the
Okay,
morning,
okay.
Yeah.
New Jersey.
Okay.
Yeah,
Maybe around
okay, we'll
8 or
start.
7.
I'm going to introduce Warwick, and he's going to introduce Ben, and Ben's going to show a clip of the in tribute to Yuha. Okay.
Okay.
Okay, here we go. 10, 9, 8, 7, 6, 5, 4, 3, 2. Good morning. This is Dr. John Bennett from Miami Beach here. We have another a webcast in the Chinese Neurosurgical Journal webcast, the bi-monthly. And today we have the honor of having James Liu. And but first, let me introduce Warwick, who's going to moderate the proceedings. Good morning, Warwick.
Good morning, John. So thank you. Today it's a very special and nice evening for my country again. Welcome to the China Neurological Journal webcast today. So our host today is Dr. Bin Su, in which he's the chief of the neurovascular surgeries from the Fudan University, Shanghai, China. So today he's going to lead the conference today and introduce our speakers today. So please, Dr. Bin.
Okay, thank you, Warrex and John, and welcome, Professor James Liu. And first, I think this week is a very sad week for us because we lost our best old friend, Yuha Hanesnemi, and this is a video for him. Can you see the video?
Yes.
Okay.
There's no audio, right?
It's yeah. Oh, I close it.
Yeah, start it again. Start it again.
Yeah. Okay.
Just start it again.
Mhm.
Thank you.
Okay, I think Professor Yuha, he is a legendary neurosurgeon, and around more than 3,000 visitors visited him in Helsinki, and in the past 5 years, he stayed in China, and more than, I think, all of the neurosurgeons from China learned a lot from him. And in the pandemic period, thank you, John. We organized so many presentations, the webinars. More than 2 million people learned from him from China, WeChat. Thank you. And we will always remember him. Thank you.
Let me just say, Ben, he was determined to come to China. He was determined to come to China to teach. That's what he wanted to do. Thank you. Thank you.
Okay, now let's give time to Professor James Liu. He will present his very interesting experience in clipping the aneurysm. Thank you.
Thank you, Ben. Hold on one second. Okay, can everyone see my screen?
Yeah,
okay,
perfect, perfect.
Great. Well, thank you, Professor Bin and John, and organizing this and this kind invitation to speak. And the title of my topic today is "The Art of the Clip: Site-Specific Clipology Strategies for Aneurysms." And in light of the passing of this great legend, Professor Yuhai, want to dedicate this lecture to him. And you can't speak about aneurysms without mentioning Professor Yuha. He was a master surgeon, a great teacher, but also had a very kind heart. And just from personal experience, I had the pleasure of meeting him in 2008 and watch live surgery that he performed. And it was mind-blowing and also inspiring. So we thank you, Yuha, for all the great contributions you've made to neurosurgery. All of the patients that you've treated are forever grateful, and we as students of the art continue to thank you for the teachings that you've brought to many around the world. So with that said, I wanted to just refer to, these are the references that I'll be referring to throughout the talk using various illustrations. But as you know, aneurysm surgery is dwindling across the globe in most parts. Many have been taken over by endovascular techniques, and the opportunity to learn how to do open surgery continues to decrease. And especially in parts of the country where there are work hour restrictions for trainees, this poses more pressure and limits on how we can train future surgeons how to do proper and safe aneurysm clipping. And so, because of the fewer and fewer cases, the aneurysms that do need to be treated are much more challenging. And it's going to require more microsurgical skills and also some bypass experience. And so it is becoming a lost art. So how can we preserve this? How can we preserve the craft? As we know that not all aneurysms can be or should be treated endovascularly and will need open treatment. And so these that have failed endovascular treatment are going to need more complex microsurgery and bypass. And so it's going to be important to master these if we're going to perform open surgery to produce good results. So I adapted this slide from Professor Lawton, and I saw him talk about achieving mastery, and he had the 3 H's. First H being hands, having good hands, dexterity, touch, and technical skill. But you also have to have a good head on your shoulders. You have to have good strategy, creativity, and judgment. And then heart. You got to have the grit, that fire in your belly to strive for perfection. And then I modified it and added a 4th H, which is hours. And this is the limits and the challenges that we face, is that oftentimes we don't have a lot of hours, and because of the limits I mentioned, but we need hours to develop experience, develop volume of cases, time under the microscope, time in the cadaver lab, time for rehearsal. And I would say because of the limits, we need to find other opportunities, which is finding mentorship, going and spending time with other master surgeons who can demonstrate, and where you can learn from deep, engaging observation. And I think in this day and age, with videos and YouTube and online learning, we have opportunities to watch master surgeons perform these operations and learn from them. And I would say during my time of training, we didn't have that capability. And now worldwide, we have these global webinars that can really benefit. So Malcolm Gladwell says it takes about 10,000 hours to become an expert, but it's 10,000 hours of deliberate practice. So those 10,000 hours need to be focused, and you need to be zoned in and focusing on the important aspects of the operation. One of the things that I do before every aneurysm surgery is I don't look at just the 2D angio, but it's important. I go to the 3D virtual machine and I reconstruct the 3D simulation of the aneurysm, and then I spin it in my mind's eye so I know what's behind the aneurysm. Is there an important vessel or perforator? And then I rotate it into the surgical view so I can already predict what kind of clip configuration I'm going to use. And it's similar to what the pilots of the Blue Angels do, is when before a flight, they sit and they rehearse everything in their mind as to every maneuver they're going to perform. So it's called guided imagery, mental rehearsal. So if we take this aneurysm, this was an ACOM aneurysm, and you can see it incorporates one of the A2s, and the A1s, one is slightly more dominant than the other, but the features you have to recognize is these are triplicate A2 vessels here. So you have to preserve 3 of them. And which side do you choose from? So when I rotate it from the left side, if I pretend that this is my left-sided surgical view, you can see that it's very feasible, but you have to use probably a fenestrated clip configuration to fenestrate the ipsilateral A2, but you also have difficulty in finding where the 3rd A2 vessel is. But if I come from the right side, you will see that the neck of the aneurysm is right between the goalposts of the 2 A2s on the opposite side and the A2 on the ipsilateral side. And you could see right side would be much easier and more favorable. So that is indeed what we did, is just come from the right side, and it was a straightforward clipping job. So you could see how 3D, I think, is very helpful, and I'll show you this throughout the lecture. Here's the postoperative angiogram showing nice reconstruction, feeling of all the A2s. I tell my residents that before you even perform the surgery, you have to think of yourself like a pilot, like an airline pilot. You're carrying a plane full of passengers, in this case, one passenger, the patient. And before you begin the operation, you need to go through your machinery. You have to go to the back table to make sure the microscope is set the way you want it. It's balanced, the eyepieces are focused and parafocal. You want to make sure every instrument that you need is on the table, because the last thing you want is a disaster where you encounter an intraop rupture and you don't have any of the temporary clips loaded. You don't have your emergency clip prepared. You don't have your third emergency suction working. So very important, go through your equipment checklist before you start, talk to your team, talk to your nurses, so everyone is prepared. You have to prepare for that unexpected disaster, and that's part of the formula for success. Some general principles. I do neuromonitoring, it's very important. It's always important to establish the proximal control, but also the distal control, because if an aneurysm ruptures and you put a temporary clip on the proximal end and it's still bleeding and you can't control it, you have to be ready to shut off the water. You have to shut off the blood flow and then handle the aneurysm. So you have to have distal control. I have a low threshold to use temporary clipping under burst suppression for brain protection. And you should pick out your clips before you open the dura. Pick out your temporary clips, pick out a potential clip you might use in case of an emergency, and always be prepared for the intraoperative rupture. So let's talk about site-specific clipology. We'll start with MCA aneurysms. This is one I did recently, about 2 days ago. This was a unruptured aneurysm, but she had a strong positive family history. Her mother died of a ruptured aneurysm, and I looked through the 3D angio, and these are reconstructions that I recreated on the virtual angio machine. It doesn't cost the hospital anything. It's the most cost-effective way of virtual rehearsal. It's the same machine that my endovascular colleagues used and make the 3D. But you cut out all the noise and you focus on the business end here, and you can see the bifurcation here is quite dysplastic. You could see it's the bifurcation itself is dysplastic. It's wider neck, and it incorporates the takeoff of the M2s, and you can see you always have to rotate it to look at all sides. And this is the back side of it. And you can see it's quite dysplastic. It goes into the bifurcation as well. And this is what it looks like intra-op. And you can see my predictive view of the aneurysm during surgery is right on target. You can see this is my predicted view, and this is what we see here. And you can see here's the dysplastic bifurcation. And under temporary clipping, I was able to deflate, and then I tried different configurations coming in, picket fence stacking, doing tandem clip, but I ended up using this curved clip coming across parallel to the axis of M2. And this has the advantage of minimizing dog ear formation when you come parallel to the M2. And this curved formation nicely reconstructs the curve of the bifurcation. And you have to look on both sides. You got to look on the front side and you got to look on the back side. And there was a remnant on the back side. And all I did was open the clip slightly and use the suction to pull the dome of the aneurysm through to pull through and under tension, so there's no more dog ear on this backside. And so here's the ICG. You can see IC green filling the perforators. This is the M1 perforator right here that we have to preserve. And here's the post-op angio. You can see very nice reconstruction of this bifurcation, and the gentle curved clip nicely reconstructs that. So that is one of many options for MCAs. So remember that. This is slightly different. This is a smaller aneurysm, but you can see it's kind of dysplastic here on the backside near the bifurcation. And this one I did a tandem clip type configuration. You generally use a fenestrated clip, not only because of closing force, but you sneak behind this fenestration here to clip the dog ear. You can see this is an example. So you can see I come in with a smaller, gentle curve clip to get the dog ear back here and for this unruptured aneurysm. Now, MCAs, when they rupture, they present with subarachnoid hemorrhage, but sometimes you can get a temporal lobe or intracerebral clot, especially with PCOMs or MCAs. And I've heard several speakers talk about doing endovascular coiling and then taking them to the OR for decompressive hemicraniectomy and sucking out the clot. I think that's a bit absurd because when you're in the angio suite and you're coiling the aneurysm, the brain is under pressure. And if the brain has mass effect and the patient is slightly herniating, you're losing valuable time. So you need to decompress the brain, take the patient to the OR, do the craniotomy, suck out the clot, and clip the aneurysm. And there's ways to do that. So let me just show you this example here. So you make a corticectomy in the superior temporal gyrus here, and you can suck out the clot, but you don't remove the whole clot because you don't want to detamponade the aneurysm. So you suck out enough to relieve some pressure. And then now you can go ahead, the pressure is off, so you can open up the Sylvian fissure, open up the arachnoid. Now what I'm doing is I'm opening up the lamina terminalis early, not at the end of the surgery, but very early, because the minute you do that, the brain all of a sudden just relaxes. You've already drained off almost 100 to 150 cc's of fluid, and it works better than opening the EVD, in my opinion. So now I can actually open the fissure. Before, the fissure was too tight, and now we're dissecting the entire M1 segment. This is the entire M1 segment here on the left side, and this is the aneurysm. You can see it's partially thrombosed. That's why it has this funny shape on the 3D. And we're gonna you have to find both M2s, and this 3D helps me understand where those are. So I have the M2 here, and the other M2 is just right here in front. So now I put a temporary clip under burst suppression, and you can see it's partially calcified, partially thrombosed. I'm gonna do a tandem clip technique where I use a fenestrated clip and focus on the distal neck. And I'm focusing on this takeoff. This is the bifurcation. This is the inferior branch of M2. And then I purposely leave a little dog ear in the back to not occlude the superior M2 takeoff. And then you clip the remnant with a smaller, either a straight or a curved, smaller clip, and sneak under the fenestration. So you're trying to clip the aneurysm in 2 bites or 2 or 3 bites, not 1 bite. And that's the whole point of tandem clipping is you reconstruct the neck so you don't occlude the takeoff of the M2s. And this is a very useful technique for wide neck aneurysms, this tandem clip technique. We do it for basilar aneurysms also. But here's the ICG. You can see nice reconstruction. Look at the brain. Look how it's not swollen anymore. You can see it's below sea level, below the level of the dura. And this patient did quite well. You can see the post-op angiogram is intact. This is a anterior temporal artery aneurysm. You could see, or it's a pre-bifurcation M2. And patient had hydrocephalus, but patient was wide awake. So instead of putting a EVD in the ICU, if the patient is wide awake, GCS 15, I'll put it during the time of surgery, intra-op, and that way you don't have to make 2 incisions. You could do it at the time of surgery here. And you see hemorrhagic subarachnoid hemorrhage that you see here. And it's very important to do wide splitting of the Sylvian fissure. Very important. You want good wide exposure of the proximal inflow and then the distal outflow. So see how the 3D, you can see this is the neck of the aneurysm here. This is the MCA, and then this is the proximal neck. This is the distal neck, and then this is a sausage-shaped aneurysm. Now I'm using a right angle probe, and you can see the right angle probe mimics the clip blade. So this is a simple technique you can use. You could pick the clip blade that mimics the angle of your probe that you're using to dissect the neck. So if I'm using an angled probe from this position that I'm sitting at, why not just use an angled clip, which is ergonomically comfortable, and just apply it in this fashion. So a pretty simple trick to use. Okay, and then here's the ICG. And then we pop the dome of the aneurysm to ensure there's no filling. And with subarachnoid cases, I routinely open up the lamina terminalis, and I also open up the membrane of Lilliquist. There's the lamina terminalis. I puncture it with an arachno knife and then spread it, and then cut the membranes with scissors to make sure it's a wide fenestration. And then working in the membrane of Lilliquist, we open up this widely, and there's some literature to show that when you open up both cisterns, your chances of a post-hemorrhagic shunt decreases. And so we routinely do that to open up all the cisterns. Here's the post-op scan. You can see aneurysm has been included. She was neurologically intact. Aneurysms, this is a more difficult one. This is a patient who had her subarachnoid hemorrhage in a different state. She underwent coiling of this aneurysm. I probably would not have suggested this up front, but you can see it's a wide neck aneurysm, complex shape appearing on the larger side. This is the coiling that was performed. You can see the post-coil, and patient moved to New Jersey, and we studied her angiographically. You can see the aneurysm still filling, and it's recurred, and that's the issue with large aneurysms in the MCA. If you coil them, they have a higher rate of coil compaction and regrowth. So what is the treatment strategy here? Should we reclip it? Should we be prepared to bypass or trap it? These are some of the things that we thought through. So we did prepare for bypass, but always try to clip it first if you can. It's a much simpler technique. So here's M1, and here's the M2, and we'll put a temporary clip on the M1, and then we'll see if we can try to coil the residual neck. But you see, you can't do that because the coil mass is pushing the clip blades down, and it's occluding the M2s. So our next option here is to open the aneurysm and extract the coils. So we trap the aneurysm with temporary clips, and then we open up the dome of the aneurysm. Now you have to prepare your sonopet or your ultrasonic aspirator ahead of time. You have to test it to make sure it's working before you do this. The last thing you want is that the equipment is not working and you're already under occlusion. And again, time is brain. So you want to make sure this is working. We do a thrombectomy, and then we remove the coils and decompress the coils. And I'm able to move it off to the side. So instead of dissecting all of it at once, I can start to reconstruct the aneurysm and not waste time, because again, time is brain. And we'll do a tandem clip configuration here. And you always want to underclip these. You don't want to make it look perfect. If you make it look perfect, you can occlude the lumen. But look at this lumen, it's blue. This M2 is blue and there's no Doppler sound, it's occluded. So what do? You have to open up the aneurysm. So I took off one clip to see if it reestablishes flow. There's no flow there. So now I have to open and take a look and inspect. So we leave this M2 off, and you want to get back bleeding. So we finally see that there's debris occluding this lumen of the M2. There's some debris there that probably occluded the lumen. So now we're going to do a thromboendarterectomy with some scissors. We cut out the debris, irrigate with heparinized saline. You can see the lumen looks much nicer. And now we'll redo our clipping and put in a fenestrated clip here, and then open this up, reestablish flow. And now we have good confirmation of flow here with the Doppler. And so now we'll finish our coil extraction. So now that the M2s are now open, we'll take the time to extract the coils, and then we'll use our tandem clip technique and reinforce the backside and then reinforce the top side. And again, you don't want to make the extraluminal reconstruction look perfect. These are thick-walled, partially thrombosed. And if you overclip it, you'll stenose the takeoff. And I felt pretty satisfactory with this reconstruction. And then we'll wrap the neck with some cotton wisp and fibrin glue. So here's the post-op angio. You can see excellent reconstruction of this complex MCA. This is a picket fence type configuration, and it's a small aneurysm, but I'll show you why I thought picket fence was good. So this is a very dysplastic bifurcation. You can see there's the dome and neck incorporating the backside. So I put a fenestrated clip on the front side, on the back side. And now I'm just using some small mini clips to reconstruct the remnant. And you can see we put one on the front side, and there's a small tiny remnant back here. We'll just close off this filling, and you can see this is a nice reconstruction using a picket fence technique. Usually picket fence we use for larger aneurysms, but in this case, you can apply it to small aneurysms that's causing some dysplastic formation of the bifurcation. And so this was a nice reconstruction. Post-op angiogram was good. This is what I call a suction persuasion pull-through technique. Whoops, sorry about that. This is a wide neck MCA. And this is the 3D that gives me an idea what we're going to be expecting. So here is the aneurysm. We have it exposed. And so we'll put a temporary clip on the M1. And then I'm going to do tandem clipping technique. I'm just going to use an angled fenestrated first, focusing on the distal neck. And then you can see the side that I'm looking on from the back side looks good. This reconstruction of this distal neck looks good to me. But then on the back side, on the front side, look at, there's a big remnant here. So now I'm going to release the clip gently and use the suction to tease and pull through the residual neck. And once I get it through the gates of the clips, I can reapply the blades and fix that dog ear. You see that? So this is called the suction pull-through technique. And I'm inspecting that M2. It looks good to me. I'm happy with the reconstruction. Now I focus on the proximal M2. Remember, I leave a little dog ear, and then you could fix it with a gentle curved clip. This is the tandem clip technique. And the M1 and the M2s are filling nicely on both the front side and also on the back side. And this is the final view. You could see excellent reconstruction on the CTA angiogram. So let's talk about ACOM aneurysms now. There's, they point in 4 different directions. This is a pretty, variety of different aneurysms you can see, and beware of the inferiorly pointing aneurysm. Sometimes when you elevate the frontal lobe, the aneurysm gets pulled off of the skull base that you see here, the tuberculum. This little microaneurysm was stuck to the tuberculum and intraop rupture, and we could just treat it like that. But sometimes they're stuck to the chiasm. So this inferiorly pointing is stuck to the chiasm, and you don't want to lift the frontal lobe and tear the neck. and you want to be careful not to injure the optic apparatus as well. So, but inferiorly pointing ones are fairly more straightforward. Out of the different ACOMs, generally you want to put the clip blades across the neck of the aneurysm, and you can, in this case, go straight across. Just identify the spaces for the blades. Anteriorly pointing are quite similar to inferiorly pointing. This is an anteriorly pointing. You can see it comes straight out, parallel to the chiasm, but you have to be able to identify both A1s, both A2s, and both recurrent artery Hübners when you're treating these. So here the clip blade goes straight across the neck, and we can clip this anteriorly pointing aneurysm. Here's another ACON. This one's anteriorly pointing. This is a left orbitopterional approach. I like to use orbitopterional for ACOMs and also posterior circulation aneurysms, as well as paraclinoid aneurysms. MCAs and PCOMs, I just do straight pterionals. But here we're splitting the sylvian fissure. Remember to mobilize the temporal bridging veins laterally. And then here's opening up the proximal cisterns over the carotid artery at the skull base, and then the optic nerve is going to be medial to this. And for ACOMs, I have a low threshold to perform a gyrus rectus resection. It minimizes the manipulation and traction on the frontal lobe, but you get good exposure of the aneurysm. It's a subpeel gyrus rectus resection, and now I can identify the dome of the aneurysm as well as the neck. And then here's the ipsilateral A1. Now I'm going to put a temporary clip on the ipsilateral A1, and then I can understand the neck of the aneurysm. When I put the blades across, I want to make sure I don't grab the contralateral A1 or the contralateral A2. So you have to identify all those. And then I like fenestrated clips, not because you need it for the fenestration, but it has a higher closing force. And so this is a thicker walled aneurysm that I can tell already. And so I like to use this fenestrated clip for higher closing force, but it's also easier to see the anatomy as the clip blades are closing. You actually have more room to look around and to visualize the anatomy. And so we're going to put a second clip here for reinforcement, and making sure with our suction that we're not occluding the contralateral A1 ACOM junction here. You can see there's the contralateral A1, and then there's a small little remnant here. The small remnants, I use a 3mm mini clip, the very useful clip just to clip off small, tiny little blisters. And there's the final configuration. And then here's the recurrent artery of Hübner on the left side. Here's A2, and you can see a nice reconstruction. And here's the post-op angio. You can see both A2s are nicely filling and straightforward. Now, the superiorly pointing ones are, I think, the more difficult ones because you generally have a ipsilateral A2 that's in your way. And so oftentimes you have to use fenestrated clip type configurations. And so here is a larger, complex, wide neck, superiorly pointing aneurysm. And with a 3D, this is the surgical view that I'm going to get here. And here I can understand the neck. Here's point A to point B. And to put a single clip across here is difficult and can risk stenosing the A2 takeoff. So we're going to do a tandem clip technique. You can see there's a little daughter teat here that we have to deal with. And so here we'll do a tandem clip technique where we fenestrate the ipsilateral A2 and then take care of the residual with a smaller clip. And this is the post-op scan. Now, this is another superiorly pointing aneurysm. We did this through a modified OZ. So here, look at this whole complex is dysplastic here. Here's A1, A2. This is it, contralateral A1. Here's A2. So we're first going to use a fenestrated clip to reconstruct this A1, A2 junction with the ACOM. And we put the first clip here. This is after doing a gyrus rectus resection. You can see I left a residual here. This is the contralateral A2. So if I just modify it and just move the clip and rotate it downwards, I'm able to protect the contralateral A2 you see in the interhemispheric fissure back here. And now I'm able to start here, start reconstructing the ACOM. This is the ACOM being reconstructed. And now I can start to stack the fenestrated clips to build to recreate the tube of the ipsilateral A2 vessel. So I put the second clip on to stack it, and you can see there's a residual neck there. And then I put the third stacking fenestrated clip. This will clip off the rest of the aneurysm. And now I've made a stacking fenestrated clip design that will reconstruct ACOM. Here's ACOM right here. And then this is A1, A2. So now the A1, A2 is reconstructed. I like to use the bigger fenestrated, the 5 millimeter fenestrated, so I don't compromise the lumen of A2. You can see A1 contralaterals here. And this is the final configuration. So stacking fenestrated construct was very useful for this particular case. Posteriorly projecting, usually the neck is usually identified within your gyrus rectus resection. And here is one that, this is a triple-headed ACOM complex aneurysm with triplicate A3s, or I'm sorry, A2s. And with the 3D, I've labeled them so that when I rotate it into the surgical view, I can keep track of which aneurysm I'm treating here. So here's the surgical view. You can see there's 1, 2, 3 aneurysms. Here's 1, 2, and 3. This patient had duplicate ACOMs and also triplicate A2s. Very interesting. I call this the three-headed dragon. So here's the different aneurysms. And we're going to treat the first one. This is number 1. This is right at the A1, A2 junction. We're going to use a fenestrated to cinch off the neck to recreate the A1, A2 junction on the ipsilateral side. And then we'll clip the remnant off with just a straight clip right on top of it. And here is the aneurysm number 2. This is partially, had a partially interop rupture. We just use a second clip. And then with this bayoneted clip, we're going to clip off number 3. It's a very wide-necked aneurysm. And this was done under temporary clipping. And then with the fluorescein angiography and icy green angiography, you could see we preserved all 3 A2 vessels, and the aneurysm was treated. Here's the post-op angiogram you can see here. So very nice reconstruction. Here's the posteriorly pointing ACOM. I mentioned this is after gyrus rectus resection. Here's a left-sided approach. A1 recurrent, A2 here. Here's contralateral A1. And we can come in from the backside. Here we could just use a straight clip and take care of this posteriorly pointing aneurysm. This is one I did recently. This is a A1, A2 junction aneurysm. This is the surgical view here that you see. And then this is the recurrent artery of Hubner. So this is the AP view. You can see it's pointing medially, but on the surgical view, the aneurysm is going to be away from you. So remember that. So how are we going to recreate this A1, A2 junction? So in my mind, I already predicted we're going to have to use angled fenestrated clips, much like a hypophyseal aneurysm reconstruction. And so that is indeed what we did here. So here is, again, opening of the Sylvian fissure, opening up all the arachnoid membranes. Here's the optic nerve, carotid artery. And then here's the chiasm being exposed. And then we do a gyrus rectus resection just medial to the olfactory tract. And subpial dissection, you can start to see the neck, or I'm sorry, the A2 vessel. Here's the recurrent artery Hubner takeoff that we saw in the 3D. You see that? And so here's the aneurysm that we're starting to see in view. And I try to preserve all of these perforators. And there's the aneurysm in the back pointing away. There's the neck of the aneurysm. Here's the contralateral A2. So I'm using this to identify the neck. This is the a hook, identifying the neck of the aneurysm. There's the other hook. And we want to make sure we can get a clip blade all the way across the neck. So it's important to do this and interrogate it before you apply the clip, because if you haven't established the potential space for the clip blade to sit, you're going to tear the neck of the aneurysm. So we start with this fenestrated clip. I want to make sure we come across. You see how the clip blade goes all the way through the neck here to reconstruct this. And then I thought we had occluded it, but you could see the aneurysm still alive after I puncture it. So I always have a clip ready before I puncture any aneurysm. Always have a clip that you think you're going to use. And then here's the application of the second clip. And then here is a dog ear in the back. We'll just use a shorter fenestrated clip to close off this last component. And there's the final reconstruction. You can see very nice reconstruction. The perforators are all open, recurrent artery Hubner. Here's the contralateral A2, which is filling. And so this was a very nice result here. You can see post-op angiogram. This is a much more complex aneurysm. This is not a pituitary tumor. This is a thrombosed aneurysm. You can see it's got the signaling on the T2, characteristic of thrombosed aneurysm, bright on T1 in some cases. Here's the angiogram showing a partially thrombosed aneurysm, giant aneurysm in the acon region. Not great for endovascular treatment. You can see this is the 3D. It really incorporates the A2 vessels here. So how are you going to treat this? So you have to be prepared to do a thrombectomy. And in order to do that, you have to identify all four vessels, right? Both A1s and both A2s, because you have to be ready to trap it when you do the thrombectomy. So we're going to open up the aneurysm here under temporary occlusion. So you have to do this efficiently when you have the ACAs clamped off. And so we're going to try to clip the aneurysm first by deflating the aneurysm. I'm going to see if I can get a clip across. And you can see it's a pretty calcified neck. And I'm going to see if I can try to not occlude the ACOM complex. So I'm pushing the clip blades upwards so that I can make room to reconstruct an ACOM complex. So I take off the distal clips, and now we're going to open up the aneurysm. Again, you want to have your ultrasonic aspirator ready, and we have neuromonitoring to detect for any changes. So now we're going to decompress the aneurysm. And we're going to cut out portions of this because it's really hard to visualize inside. And once you've cut out enough of it, we can start to reconstruct. And I'm going to take off the bottom clip so I don't stenose the ACOM complex. And then we'll go ahead and reconstruct the rest of this now that we've cut out a good portion. So this is called, stacking and then removing the bottom so you don't stenose the underlying ACOM complex inflow. So there's still some bleeding from the aneurysm here, so we'll go ahead and come in with a different configuration. This is a modified tandem configuration. You can see I'm clipping the distal neck here and then reinforcing it in this manner. And then we'll remove the temporary clips from the A1 vessels. And remove the temporary clip from the A2s. And here is the ICG. You can see A1s and A2s are filling. And the ACOM complex is filling here. Here's the A2s. And that completes the aneurysm clipping. So here's the post-op angiogram. You can see the A2s are filling here and a nice reconstruction. PCOM are aneurysms. Here's a PCOM aneurysm, very straightforward one. Here's a larger PCOM. You could look at it with an endoscope. And here we're just using a bayoneted clip. A pretty standard straight clipping for laterally pointing PCOMs. You have to see the PCOM knuckle and you have to see the choroidal takeoff so you don't injure the choroidal takeoff. This is another PCOM. I'll just show you. Here is the PCOM takeoff, and then you can see it's already ruptured. So you can encounter an intraop rupture, but don't panic. Keep your suction in the field. The last thing you want to do is remove the suction. We're using the suction to protect the choroidal. Here's the choroidal vessel right under the suction, and we're using it to protect the choroidal so that when we apply the clip, we don't injure the choroidal. And this is actually one of my chief residents applying the clip and managed that intraop rupture nicely. Let me just go to the second. I just want to talk briefly about managing intraop rupture. This is a large PCOM aneurysm. And just want to show you what happens when you encounter a rupture. So here's the proximal clip, proximal control on the carotid. And then here we're clipping the PCOM aneurysm. This is a laterally pointing aneurysm. Here's the PCOM knuckle. And you'll see we're trying to open up and dissect the laterally pointing component here. We're freeing up the dome now from the temporal lobe, and it ruptures here. So aneurysm obviously is not completely occluded. So my first step is to just apply a clip. Maybe I can grab the rupture site, but here I can't really see anything. So I'm going to put my proximal temporary clip on the carotid again. And now I'm going to close out the distal end. And then now I can re-inspect to see what's happening, reapply the clip. And looks like I had torn the neck of that aneurysm. And so you could see that's one way of handling it. So again, proximal and distal control is very important. And here's the third nerve. So, and here's the post-op angiogram. Ben, am I going over time here?
No, please.
I can keep going?
Yeah, no. Yes, you're welcome.
Okay. I'll try to get through this last part quickly. So I just want to talk about ophthalmic paraclinoid aneurysms. You often have to do a clinoidectomy in order to get adequate exposure. You can do it extradurally, or you can do it intradurally, clinoidectomy. And the configuration I like is this side curved clip, where you come in and then you rotate your hand so that the clip blades are more parallel to ICA. And so here's an example of using that side curved clip. This is a right-sided ophthalmic aneurysm. You can see the dome of the aneurysm is compressing the optic nerve. So we'll come in with a side curved clip, and then as the clip blades go across the neck, we can begin to rotate our hand so that the shank of the clip is pointing anteriorly and the clip blades are pointing parallel to the ICA. And so this is a nice way. And this is after opening up the distal ring after doing a clinoidectomy. This is a lady who had multiple aneurysms. You could see she's got an MCA here, an ophthalmic here, and a superior hypophyseal here. And you can try to do this in one treatment. So you could save multiple endovascular treatments and do this through one treatment. This is how I take off the clinoid. I cut the meningorbital band and I unlock the cavernous sinus. And then we unroof the optic nerve, wide splitting of the sylvian fissure. And then here's the MCA aneurysm. You can see we're going to identify in the neck. This is the MCA. And this one is pretty straightforward, just a straight clip here on the MCA. And then there's a little blister here. Do you see this little blister? There's a little blister here on the bifurcation. This little blister, this is where I use that 3 millimeter straight clip, mini clip. Very easy to apply. You just be very gentle and just clip off the little blister. And now we'll open up the falciform ligament here. This is the optic nerve. And then this is the superior hypophyseal aneurysm on the opposite side. This is the contralateral optic nerve. Here's the contralateral carotid. And it's very favorable to clip right here in the prechiasmatic cistern. You can come in with a gentle curved clip and then just close off that aneurysm. And then here's the opening of the falciform. So you have to open up the falciform. Here's the ophthalmic, typical location just underneath the optic nerve. And we want to, look how thin-walled it is, very thin-walled. You got to take off all the arachnoid tissue around it to be able to visualize the neck better. And so now I'm putting the blades to recreate the blades of the aneurysm clip itself. But here I get into an intraop rupture. So again, don't panic. Leave your suction in the field so you don't lose your position. The minute you move your suction and blood goes over the place, keep your suction in the field, ask for the clip in your other hand, and just try to clip it. So here we already prepared for a straight clip, and just going across the neck of the aneurysm here, and we were able to take care of that. So keeping your suction in the field prevents a disaster. And so the MCA looks nicely reconstructed here. For these giant paraclinoid aneurysms, certainly flow diversion has really changed the game. This is an aneurysm that I did before the flow diverting era, but Professor Sugita is credited to really developing the concept of fenestrated clip reconstruction, and Bajer and Sampson, introduced to us the suction decompression technique, which I'll demonstrate. Here is a giant aneurysm ophthalmic where we do the retrograde suction decompression. You have to open up and expose the carotid. And so here we are doing the clinoidectomy, opening up the Sylvian fissure, opening up the falciform ligament. You can see the optic nerve is completely stretched by this aneurysm. Open up the distal dural ring. And then here's the distal neck of the ophthalmic. We're gonna trap the aneurysm we'll put a clip on the external, a clip on the common, and Sampson and Bajer would puncture the ICA, but I prefer to do the common. It's less traumatic to the internal, less risk of dissection. So we'll put a butterfly needle here, and then we'll decompress and aspirate in a retrograde fashion the dome and the aneurysm. So now this gives me time to dissect. Here's the ophthalmic artery takeoff. Here's the proximal neck. Here's the distal neck. Here's the optic nerve. And so now I can come in with a side curved clip and slowly close the blades here and reconstruct this aneurysm. And here's the ophthalmic takeoff. And then we could take the butterfly needle out and just repair the entry site, single stitch. And then here's the ICG angiography. So a nice reconstruction. You can see this is the retrograde suction decompression, a very useful technique for paraclinoid aneurysms. And then you can also do direct decompression. This is an example where this is a giant hypophyseal aneurysm, and you could trap it directly. I put a temporary clip right on the clinoidal segment of the carotid, a clip on the distal ICA, and then you could take a butterfly needle and puncture and deflate the aneurysm, and then reconstruct this in this fashion, much like the diagram from Sugita. This neck here is very calcified. You can see there's a very calcified remnant here. There's a dog ear from this piece of calcification. So whenever there's calcification, you just clip the soft parts of the aneurysm to help reconstruct it, work around the pieces of calcium. But at the end, we were able to nicely reconstruct the tube here and get a nice ICG filling. And then here's the reconstructed carotid. And here's the post-op angiogram. Giant ophthalmic. This was in the pre-flow diverting era, but nowadays you could probably divert this, but this is one where there was no ACOM collaterals. And so we were we have to be prepared to sacrifice the carotid if there's intra-op rupture. So we do a prophylactic bypass. This is an ECA saphenous vein to M2 bypass. Here's the M2. Here's the distal anastomosis to M2. Here's the proximal anastomosis to the external carotid end to side. And then we clip the aneurysm. We were able to clip it. And then here's the bypass, still intact, prophylactic bypass. And the aneurysm is taken care of. Expanding the carotid oculomotor triangle. This is important for posterior circulation, basilar aneurysms. Here's a ICA with basilar aneurysm complex. You could see this is an ICA, probably PCOM aneurysm, and this is the basilar. It's not a big aneurysm, but it's complex in that the bifurcation, it incorporates the P1 here, and difficult to do endovascularly. So we did this at the same time. We did a clinoidectomy, wide splitting of the sylvian fissure. And then you'll see here's the carotid aneurysm, pretty fusiform. And put a temporary clip here. And then we'll reconstruct the carotid using angled fenestrated clips. And we do a single right angle fenestrated and then a straight fenestrated to get the rest of this neck here. And then one more to reinforce the other clip blades. So now that the carotid's taken care of, we can move it off to the side, open up the carotid oculomotor triangle. This is a PCOM perforator. I'm going to keep this intact and work around it. But here's the basilar aneurysm, and we're going to do a tandem clip technique. This is the contralateral P1 working in the carotid oculomotor triangle. So you're going to do a tandem clip where you use a straight fenestrated clip, and you're going to focus on reconstructing the distal P1 neck. So we're focusing on the distal neck, making sure we preserve the contralateral P1. And now we're going to inspect, and then this is the residual here on the back of the basilar complex. We see here's the ipsilateral P1. There's just a bulbous formation here. So I'm going to try to use just a straight clip. And then as I'm closing it, I'm lifting up. So I push up against the basilar bifurcation. And then this is the final reconstruction. You can see here's the basilar final reconstruction, nice reconstruction of the carotid. I'm just going to skip this for the sake of time. I'm going to focus in here on, this is a distal pica aneurysm. You can see it's fusiform, difficult to do endovascularly. So how would you treat this? Do you excise it and reanastomose end to end? I thought about that as a treatment, but of course, try to do the simpler operation, which is to directly clip it first. And if you can't, we'll be prepared to do end-to-end reattachment. So this is a midline suboccipital approach. And here is one pica coming through. Here's the neck. This is the rupture point. So here is the proximal pica. This is the distal pica going this way. Here's the aneurysm. So I do a pre-clipping ICG. Now I'm going to trap the aneurysm. And there's the neck of the aneurysm. And so now we're going to puncture and deflate it first. So this will allow me to reconstruct it. And I'm going to see if I'm able to reconstruct it first. If I can, that's what I'll do. So I come in with this straight clip here to focus on the distal neck. And once the distal neck is taken care of, I realize I'm just going to stack and reconstruct this aneurysm here. So it's a stacking picket fence-like reconstruction. And then do a reinforcing clip here. So this is the final configuration. I'm pretty happy with the reconstruction. I didn't have to excise it and reanastomose. And then we'll do an ICG here. So I'm pretty happy with this, this reconstruction here. So here's the post-op 3D angiogram. This one was a distal, this was a ruptured aneurysm from a ICA-PICA complex. So this is the pica loop on the opposite side. And then this is the aneurysm from the other pica, but it's not a pica, it's an ICA-PICA variant. So the aneurysm is coming from an ICA-PICA anastomosis. And so the aneurysm is in the parenchyma. It's not in the subarachnoid space. So you had to open up the parenchyma to find the aneurysm and to treat it. So a little interesting and tricky here. You can see this is the ICA-PICA variant. And these are the clip blades here. So ICA-PICA aneurysm. And then lastly, I show you this fusiform dissecting pica aneurysm. This one is difficult to treat endovascularly. You need to do a bypass. So here we're doing a pica-PICA anastomosis. You can see we've opened up the arteriotomy at 2 and 10 o'clock using the arachno knife here, sizing up the lumens adequately, and then we'll start with our anchoring stitch. And then we start suturing, we throw it behind the knot here and then start suturing the backside intraluminally. And instead of doing one continuous stitch, I like to tie it and then start a new one just in case the back wall has a problem. I don't want to, break the knot and have to restart from the beginning. So I like to do this in 2 steps and then just suturing, running the front side, removing the clip blades, and then doing an ICG. You can see a nice ICG, and then we do a nice floor scene angiography as well. And then once anastomosis is done, we can go in and trap the proximal dissecting pica aneurysm. Here's the pica being trapped in proximally and distally. So here's the post-op scan. You can see here's the pica anastomosis. Nicely done here. Okay. So in conclusion, I think there still remains a role for open surgery for aneurysms. We have to be able to maintain proficiency and expertise, and we got to be dedicated and committed and find mentorship to improve our skills in order to preserve the craft. And we have to continue to develop our expertise in bypass, as this will play an increasing role with aneurysm treatment in this endovascular era. Thank you very much, Bin. Welcome any questions.
Thank you. Very nice presentation and very clean surgical field, and your hand is very stable and very nice techniques. Thank you very much, Dr. Liu. And there's some question from the audience. First question is, during suction decompression technique, how much time do you take to dissect and clip the aneurysm? As once we put a needle in CCA and start decompression, we can't take it off.
Yeah, I would say the time of the decompression and to just dissecting the neck, maybe about 20 to 30 seconds, and then applying the clip, probably takes another 30 seconds, but you can probably tolerate temporary clamping for probably 2 or 3 minutes is very reasonable. So, and then you can always you can always reestablish flow if you have to, but yeah, it's pretty tolerable.
Yes, another question is for during suction. This is the same. Another one is they want you to talk about yourself, introduce yourself. Which, where are you from and what hospital you work at?
Oh, okay. Yeah. Yeah, my name is James Liu. I'm a professor of neurosurgery at Rutgers University in New Jersey, and I practice at two hospitals in our system, which is University Hospital in Newark, New Jersey, next to the airport, Newark Airport, and then another hospital called St. Barnabas Medical Center in Livingston, New Jersey. I specialize in open vascular skull base and endoscopic skull base surgeries.
James, I have a question because, our team is a hybrid team. Talking to myself, I both doing the open surgery and the interventional treatment. Just as you mentioned that interventional treatment now is more and more popular, and because it's very easy to operate and no lesion. So actually, for the proximal occlusion, we can use balloon catheter to insert from. So for this kind of condition, you don't need to open the neck to get the proximal control. So if you have a vascular team, interventional team, you can ask them to occlude the neck, the ICA using balloon catheter, and then you just clip the distal. Then you can suction, and it's very easy.
Yeah, that's a very nice technique. It's the modified endovascular version of the Bajer-Sampson technique. It's
yes. Now we do more and more combined treatment at the same hybrid operating room.
No, that's a very great modification. Yeah.
Okay, Harshad, do you have any comments or questions?
Hi, James.
Hello.
Hi. Wonderful technique as always. And you have demonstrated all the aneurysms, anterior circulation and posterior circulation in one lecture, and wonderfully done and good technique. I just wanted to have a couple of things to ask. One is, do you use adenosine before putting a clip there so that the aneurysm is slack? And second, when you use a temporary clipping, do you use any neuroprotective things to allow that?
Yeah, great question. So we do have adenosine available, and we're prepared to use it. But in general, if you can put a temporary clip, proximal control, you generally don't need adenosine. So you can deflate it if you have proximal control. But if you're in a deep area, say you don't have good proximal control on the basilar trunk, you can use adenosine. Or if all hell breaks loose and you have an intra-op rupture you can't control, adenosine is a good solution. But in general, for brain protection, I use propofol, put them in burst suppression with EEG monitoring, and steroids.
Okay.
Whenever there is a blister aneurysm, say maybe on a PCOM, when you are putting a small clip there, is there any reinforcing material you use before you put a clip there? Otherwise, the clip may slip off and may rupture. Do you have any experience like that, or you just put a simple clip?
Yeah, it's usually a small clip for a small blister sometimes does the trick, but sometimes you have a wider blister where the clip doesn't stay and it slips off, in which case I leave the clip on if it slips off. Then I come in with a second clip in front of it, because now the first clip acts as a stopgap to hold the second clip, so the second clip doesn't slip off and stays on the neck. But if it ruptures, then what you have to do is trap it and then reconstruct the hole with a clip.
In a ophthalmic aneurysm, sometimes I've observed partly extradural and partly intradural. Did you have a similar kind of a situation ever? And if you, what do you do? Partly extradural.
Oh, I like to do a hybrid. So I like to do extradural first and drill off 90% of the clinoid. And then the most distal part that goes very deep, I do intradural under direct vision. I think it's safer. So I do a hybrid.
Okay, okay. Fantastic. Very nice, very nice. Excellent. Thank you.
Okay.
Okay,
Ben,
thank you, James. Now
Okay.
let's move on to the second speaker, Dr. Song Ye.
Okay, let me show the point. Can you hear me?
yes.
Yes.
Could you introduce yourself, Dr. Song, briefly?
Okay. Good evening, professors. It's my great honor to be invited for the presentation tonight. I am Dr. Ye Song from Department of Neurosurgery, Nanfang Hospital, Southern Medical University. Today, because I focus on the pediatric neurosurgery, today I have a topic about the challenge in the management of intracranial gene cell tumors, 20 years retrospective review from a single center in South China. This is the paper data from the United States. You can see the distribution in children and adolescents aged less than 19 years of all primary malignant and non-malignant brain and other central nervous system tumor by the site and the histopathology. You can see the primary central nervous system gene cell tumors are rare tumors, and they account for just 3.3%. However, the incidence rates in East and West countries were significantly different. In West countries, CNS GCT accounts for approximately 3 to 5% of all primary CNS tumors in children. The incidence is substantially higher in Asian countries, such as Japan. It accounts for 10.3% for all pediatric CNS tumors. And the highest frequency of new cases occurs in the second decade for all database. And the tumor frequency was found to progressively decrease with the increased age, and with few cases being diagnosed after age 13. And the incidence rate was also higher for males than females. The CNS GCTs are highly heterogeneous and has been divided into 8 types, such as immature teratoma with mature teratoma, and so on. And according to the classification of WHO 2021 edition, in addition to the granuloma, other subtypes was collectively referred as to non-granulomatous GCT, also called NGGCTs. This is the tumor markers of the GCT, like contains beta HCG, AFP, PLAP, and c-KIT. In Japan, they were divided into 3 subtypes, like good prognosis, intermediate prognosis, and poor prognosis groups. Moreover, the European classification method divided into circulatory tumor and non-circulatory tumor depends on the serum or the CSF, beta HCG or the ALP levels. This is the summarized of the image and the histopathology, pathological findings and immunohistochemical findings and the tumor markers according to the WHO histological classification. The treatment strategies and the prognosis of CNS GCTs are strongly related to the histological subtypes. Like the pure genome was highly sensitive to radiotherapy and chemotherapy, and the 10 years OS could be more than 19% treated by the radiotherapy and platinum basic chemotherapy. And it is the consensus, the CSI is not necessary for localized genomas, and the chemotherapy has also effort to reduce the radiation therapy doses. And the law of the tumor resection in genoma was controversial because it might increase the risk of the neurological or the endocrine or neurological degeneration, but did not lead significantly better survival compared to the genomas. And the NGGCT are associated with the poor prognosis and the higher risk of recurrence. Also, it was clear that multi-approach with induction chemotherapy or followed by the radiotherapy is the key outcomes. But the standard care treatment approach for the NGGCT remains unclear. Previously, studies have shown that the surgical resection can improve the survival of patients with localized NGGCT. However, the timing of the surgery is still controversial, and there is considerable variation in North American, European, and Asian approach. This, sorry. This paper is a review. This paper is a review for the Society of the Neuro-Oncology and the European Association for Neuro-Oncology to describe how Western cooperative groups have developed specific consensus on most aspects of the diagnosis and the management of this NGGCT, avoiding initial surgery when the CSF or the surgery markers are positive, and using the CSF cytology with spinal MRI to define the metastatic disease is a hallmark of this change. The combination of surgery and chemotherapy and radiotherapy is accordingly. NGGCTs are essential diagnosed by the positive markers and less often by pathological. And they are benefit from the chemotherapy followed by the aggressive surgery in case of residual. This paper is from the Japan Society for Neuro-Oncology. It is defining the standard of care and answering the outstanding clinical questions. And for this review, when the GCT is suspected, histopathological diagnosis is recommended to achieve the definitive diagnosis is different from the European cooperation. So the surgical intervention, such as the endoscopy, third ventral colostomy, and is strongly recommended to treat the hydrocephalus. We conducted a retrospective mono-center analysis using the medical records of patients diagnosed with the primary CNS GCTs in our institution between the January 2004 and May 2021. The study included 358 patients. Analysis of the tumor site distribution reveals that the Pioneer Ridge was the most common site of GCTs, according for approximately 16% of all cases. And the second and the third common site is the subcellular area and the basal ganglia. In addition, the total tumor marker negative rate was the 66.9%, and the 18 was positive for HCG around, and 7.7% positive for the ALP around. The CNS GCTs accounted primarily in children and adolescents, and with the approximate about 75% of the patient diagnosed between the age from the 8 to 21 years in our department, and the patient aged 13 and older was rare, accounting for only 3.1%. The highest number of patients was found in males and females at age 13 and 10. And in general, there were significantly more males and females patients in Pioneer Ridge. The male to female ratio was associated with the tumor site, but in the supercellular, the ratio of male to female patient was 1:1. The treatment regimen for the geranoma groups, patient usually receives 4 courses chemotherapy of the EP regimen. E for the anthracocyte, P for the ciplatin, and for the NGGCT groups, if patients with the mature teratoma were treated with the surgical resection without the radiotherapy and the chemotherapy, and if the patient with other NGGCT we treated with the 6 courses atomic chemotherapy of EP and IE regimen, and followed by the radiotherapy. The ratio of the gross tumor resection in Pioneer Ridge region is higher, and the ratio of the partial resection and biospire is lower. So in the Pioneer region, the GCT, we think the surgery is more active. However, the proportion of the biospire and the partial resection in the basal ganglia and the supercellular was higher, but the operation was relatively conservative. This is the protocol of our department. We divided into 2 types. First is the patient with the elevated tumor markers. We do the neoadjuvant chemotherapy and performed for 1 or 2 courses. And we after that we for the evaluation to decided the surgery intervention is whether is required, and we do following the adjuvant chemotherapy and the radiotherapy. The other hand, if the patient with normal tumor markers, if the pure geranoma was highly suspected, we do the endoscopy, biospire, or the diagnostic chemotherapy or diagnostic radiotherapy. But for the other type, we do perform the surgery directly. Let me introduce the typical cases. The first case is the 3-year-old boy. We can see the left basal ganglia is the big mass tumor. The HCG is higher, so we can diagnose the NGGCT essentially by positive markers with no pathology. We do the neoadjuvant chemotherapy. After one cycle, we can see the tumor size shaking obviously, and the tumor partial response. So we finish the chemotherapy and the radiotherapy. It's another case. 8 years ago, we can see the supercellular area. The tumor marker, the AFP and the beta HCG is higher. Also, the NGGCT can diagnose, and we no need the pathology, and we do the neoadjuvant chemotherapy. After 2 cycles of the chemotherapy, we can see the tumor size shifted, and the tumor marker decreased to the normal, and the tumor stable. So we can to evaluate whether the surgical intervention is required for the supercellular area, where we just to keep going to the chemotherapy and radiotherapy. This is another case. 12 years boy, and the pioneer age. We can see the AFP is more than 7,000. We do the neoadjuvant chemotherapy, and after 2 cycles of chemotherapy, we can see the tumor is shifted obviously, and the AFP level is decreased to the normal. This previous 3 cases is the treatment protocol is consistent with the European guidelines, and this one is the other cases, and it is a 3-year-old boy. We can see a big tumor in the pineal region, contain the solid partial and the cystic partial. And we do because of the tumor marker is positive, we do the neoadjuvant chemotherapy. After the 1 cycle, we can see the solid of the tumor is shake, and we keep going to perform another chemotherapy, and after 2 cycles, you can see the solid component of tumor disappeared, but we think the racial part is not sensitive to the chemotherapy. So we need to evaluate whether surgical intervention is required. In our department, we protocol, we do the surgery, and we do we can see after the surgery, the MRI scan, the surgery, the tumor is total gross resection, and the histopathological diagnosis is the mature tendenoma. This is another case. We can see because the tumor markers is positive, we do the neoadjuvant chemotherapy. After 1 cycle of chemotherapy, we found the size of tumor didn't change. So if we keep going to the perform the chemotherapy, we think the tumor size is not changed also, and because the competence of the tumor is the pathological is not sensitive to the chemotherapy, so we don't do the chemotherapy, and we do perform the surgical directly. This is the MRI scan. we can see the tumor is total group resection. The pathological diagnosis is mutual teratoma. Of course, this is not all the patient adopt this strategy, such as the patient. In this case, the proportion of the synthetic components of the tumor is large. And even if the chemotherapy is effective to the solid of the tumor, and there was no if the extent of the tumor shrinkage is not is estimated to be limited, so we do the performance the surgical resection directly. So after the surgical, we can the pathological diagnosis is immature teratoma. Okay, we talk about the tumor markers positive the protocol. If the tumor markers is negative, it contains the pure granuloma or the mature teratoma or the immature teratoma without the circulatory function or the embryonal carcinoma or the combination of two or more of the above types. Because of the sensitive to the chemoradiotherapy, we need to treat differently. For the pure granuloma, the biopsy is recommended because the biopsy can it also can relieve the hydrocephalus, but it also have the limitation, like the tissue is very little and the positive rate is not higher, and the pathological diagnosis is not inaccurate. For the NG-GCTs, the surgical explanation maybe can place the patient at the risk of the surgical related complications, such as hemorrhage or the infection and the inconclusive histopathological result, and the more patient maybe have the second look surgery. In our department, if the patient the clinical presentation satisfy the four criteria, and we can diagnose the pure granuloma clinical, like one is the age. If the age is older than 3 years and younger than 25 years, and the third is the gentle, particularly in the pineal area, because the man is accounted for the almost. The third is the clinical presentation, like the supercellular. The patient has the diabetes insipidus. The fourth is the image features. The CT shows the basically uniform tumor density for all. The MRI showed the basic uniform tumor single. Like enhanced scan showed the moderate or the to the significant enhance. So if the patient the clinical performance is match, we diagnose the pure granuloma is highly suspected. If the granuloma is highly suspected, we do the diagnostic chemotherapy. This is the case. You can see the first the age is 80 years old, and the gentle is male in the pineal area, and the typical image is the typical of the pure granuloma. So we do the diagnostic chemotherapy. We not do the biopsy by the endoscopy. After the one cycle of chemotherapy, we can see the tumor the tumor size shifts obviously, and the hydrocephalus is also relieved. This is the other is the next the other case like the pure genoma is highly suspected. We do the diagnostic chemotherapy. After 1 cycle of chemotherapy, the tumor is almost disappeared. This is the other case, another case in the supercellular, and the patients have the diabetes institutes, and also the tumor marker is negative, and but we think the patient's clinical presentation is match the pure genomas. So we do the diagnostic chemotherapy. After 1 cycle of chemotherapy, we can see the tumor is disappeared. Okay, for the tumor markers, if it is not the pure genoma is not suspected, we like if it is the mature teratoma or the immature teratoma, we do the perform the surgery directly. This patient is the MRI did not conform to the typical feature of the genoma, and the tumor marker is negative. So we perform the surgery. We can see after surgery, the MRI scan, the tumor is colloquially resection, and the pathological diagnosis is immature teratoma. This is another case. We do the tumor marker is negative and didn't match the pure genoma criteria, and we do the surgery directly. The pathological diagnosis is mature teratoma. And this another case, Pioneer Ridge, 3 years old girl, and the image is not the typical, and the tumor marker is negative, and we do the surgical resection, but not do the biopsy, because if did the biopsy in endoscopy, although the biopsy endoscopy is performed and the NGGT diagnosis is clear, we also need after the radiotherapy and all the chemotherapy, the tumor size can't change. So we do the surgical resection directly. So after the surgery, the histopathological is the NGGT. The pathological components contain the immature teratoma and the genoma. But in the cellular region, it is different. We can see the other case. This is a 40 years old girl. The clinical presentation is ballroom and decreased version, but it didn't have the no polydipsia. So we think it is may not the GCI tumors. So and the tumor marker is not positive. So we perform the surgical directly. After the scan, the MRI scan, we can see the tumor is disappeared, and the pathological diagnosis is pure genoma. After the surgery, the patient disappear. The patient occurred the pan-hyperpituitarism and central diabetes institute is being instituted, and but it is very sad that after the discharge, the patient dies because of the high fever. Maybe the reason is the pan-hyperpituitarism. For the survival and analysis, the genoma is highly cerebral tumors with a favorite OS basic on the radiotherapy and the planet basic chemotherapy compared to the NGGCTs. In our studies, the 5-year overall survival was 96% in the geranoma group. Moreover, there was no significant difference between the tumor resection and the no tumor resection groups on the OS for the geranoma patient. But for the NGGCT, the tumor resection group has a good prognosis than no tumor resection groups. In our department, we also have the patient, both the intracranial and the extracranial gene cell tumors were present, and the ectopic recurrent gene cell tumors because of the time limit. I can't introduce you in details. For the summary, the intracranial gene cell tumors are rare CNS tumors that medically infect children and adolescents with a peak incidence between 10 to 19 years. Men are more commonly affected than women, and especially in pineal region. There was no significant benefit from surgical treatment in geranoma around. We strongly recommend against aggressive resection of geranoma. For the NGGCT, other than mature teratoma, resection of resident tumor following the chemotherapy is strongly recommended. Aggressive surgical treatment can significantly improve the overall survival rate of NGGCTs. For the elevated tumor markers, the chemotherapy and the radiotherapy can be performed directly without the pathological diagnosis. Most of the patients are mixed type. But if the patient with the cerebral region and the basal ganglia region, surgical indications should be directly controlled because of the surgical. The patient may be the surgical related complications. But for the patients with the pineal region who eventually need surgery, neoadjuvant chemotherapy can improve the safety of the surgery while taking into account the patient's surgical tolerance. Early surgery seemed more reasonable. In our department, we after the full cycle of chemotherapy, we to evaluate the surgical intervention. And at present, the selection of the indication for the endoscopy biopsy of pineal region tumors is not strict, which makes some patients bear the risk of two operation. Because the tumor marker is positive, the NGGCT, the diagnosis is obviously. So we think the endoscopy biopsy is not needed. For the normal tumor markers, in principle, there should be pathological diagnosis, but in some patients, the location of the tumor is special and is difficult to obtain the pathological diagnostic specimen, or the cost is too high. The diagnostic chemoradiotherapy is still reasonable. Regarding to the diagnostic chemotherapy in the treatment of pure geranomas, it is important to select the clinical diagnostic cases reasonable. After the diagnostic, the radiotherapy should be still be performed. For cases of the pure geranoma in pineal region that did not match the typical clinical and the image manifestation, active surgical treatment should be performed. this is the introduction of our pediatric neurosurgery team. And that's all my report presentation. Thank you for all your patience. Thank you.
Okay, thank you. Thank you, Professor Song. Any questions? Akash.
Yeah.
Yeah,
Thank you.
please.
Thank you. I'm Dr. Kon from Tokyo, Japan. Thank you for the great lecture. So we have seldom experienced germ cell tumors, but we have some complicated diagnosis and management. So endoscope biopsy is not accurate these days. Cannot diagnose pure mixed germinoma, but we have to sometimes we have to biopsy and perform chemotherapy and radiotherapy. And thinking of the reference thinking of the reference, so we have to consider surgery. So as for surgery for complete resection, which do you prefer, occipital transcentral approach or supracerebral SCIT? Do you prefer supracerebral infratemporal approach or occipital transtemporal approach for total removal?
Unmute, Dr. Songi. Unmute.
Okay, great questions. And if this is two type. One is if the tumor marker is negative, and the clinical manifestation, clinical presentation is match and in my PPT match the pure germinoma. We do the if the patient have the hydrocephalus, if it match the pure germinoma, we do just do the diagnostic chemotherapy. Because if it's essential, the chemotherapy and the tumor size can shift obvious, and the hydrocephalus can release. But the other side, if the tumor marker is if the tumor marker is not is also negative, and is not the clinical patient clinical is not matched the pure germinoma, but we can diagnose by our experience is NGGCT. We do the surgical directly because the surgical directly, if we perform the total resection, the hydrocephalus also can release. For the other hand, if the tumor marker is positive and they have the hydrocephalus, so we do the EVT. We do the EVT first. Yes. If the tumor is in the pineal region, we do the EVT. If the pineal tumor is the supracellular, maybe the EVT is cannot performed. We do the VT. But
okay, so you prefer you do total removal. So from the posterior side, you prefer upper one, supratemporal or infratemporal? Supratemporal first.
Supratemporal first.
Approach.
Yes.
Okay, thank you. Thank you. Okay.
Okay, thank you. Thank you, Dr. Song, and thank you, Takash. Chang?
Yeah, I don't see any questions, Ben, in the chat, so I think we can wrap up, if that's okay with you.
Thank you for Professor. Have a good night.
Yeah, thank you for presenting, and thanks, Ben, for putting that UHA tribute together. He's the one that brought us to you, Ben. And I'd like to thank you, Dr. Wan and Lee and Dr. Songi, excuse me, and thanks all the participants for coming. So Okay,
Thank
we'll
you.
see. We'll
Okay,
see
thank
you
you.
in
See
2
you.
weeks. 2 weeks.
Okay.
2 weeks.
See you.